I will set off by inviting Dr. Devadasan, who indeed in recent days has been assisting the Ministry of Health in preparing a construct for national health assurance, which focuses, of course, on universal health coverage, and therefore has had an opportunity to move not only from the realm of research but also into active policy engagement to tell us how he feels that HPSR can actually help us advance in this direction.
Thank you, Dr. Reddy. What is the relationship between universal health coverage and HPSR? I was going to talk a little about universal health coverage, but thanks to Dr. Meenakshi, I don't have to. I think she has very clearly explained it, so I don't have to go that route. I'll straight away jump into the relationship between UHC and HPSR. And here I would like to take the example of Thailand. Dr. Barbara talked about it earlier. It's a very good example where the researchers and the implementers, the providers, worked hand in glove over a period of 10 years, from the 90s till 2001, where they developed various evidence to move on the path of universal health coverage. So the regular health systems, they generated evidence from their management information systems on what was happening, how many patients had tuberculosis, etc. How many patients were attending the outpatient, how many patients were paying out of pocket, etc. The researchers within the ministry understood and generated evidence on why this was happening, did research on how either the problem can be solved. So a combination, a very good partnership between the researchers and the ministry helped the government in 2000 to say, okay, this is where we are and this is what we need to do to achieve universal health coverage. Now, if we come to India, I think we are in a very different situation. I'll start with our management information systems. As many of you know, currently the management information systems in our country just collect only facility-based data, and that too only from the government facilities. So which means that we get only part of the picture. Then of course there's usual under-reporting, over-reporting, and then tweaking by the managers at various levels to appease their bosses. So what we have is that at this point in time, we do not know, for example, how much money is being spent on healthcare. We do not know how many doctors and nurses there are in the country who are working. We do not even know how many malaria cases there are and how many malaria deaths are there. For example, if I take the latest National Health Profile report, which was just released a couple of weeks ago by the minister, it says that there are only 369 malarial deaths in the entire country in the period 2012-13. If anybody has worked in Orissa, they will know that more than 200 deaths happen every year in one district itself. So what are we talking about, 369? So our policy maker is in a situation where he or she does not know what is happening. And this is a good opportunity for the traditional biomedical researcher to shed light on what is happening. But unfortunately, the traditional biomedical research does not tell us why this is happening or how to resolve this problem. And this is where health systems and policy research comes in, because it has very different methods and methodologies. For example, it brings in elements from economic research, it brings in action research, operational research, all these elements to understand why, for example, women are dying in districts where there are CHCs have 4 specialists. That's our norm. IPH's norm says each CHC should have 4 specialists. But yet you go to those blocks and still women are dying children, neonates are dying. So why is that happening? And for that, your traditional research does not give the answer. Your HPSR will give you the answer. Similarly, today, Rajasthan model or any other model, generic medicines are available free of cost in various PHCs and taluk hospitals. But people don't want it. People still prefer to go out to the private pharmacy and buy it. Why is that happening? So these are the questions the policy maker needs to get answers to. And of course, my favorite question is, in spite of various policy recommendations, why does the policymaker still limit our health spending to 1% of GDP, though they are willing to waive off 36 trillion rupees for the industry as tax waivers? So these are questions that as HPSR we need to ask, as researchers we need to ask. And finally, many of the time in our country, research, if I look at the last 20 papers published by Indian authors on India, it is all descriptive research. What is happening? We are not asking, how can I resolve this problem? We are not talking of experimental studies. And here I am not talking of randomized controlled trials, but also quasi-experimental studies, cohort studies, to find out, to inform the policymaker that if you do A and B and C, this will change. If you do task shifting, we have done task shifting in so many taluks, and we have shown that there is better access to health care. Because today when you talk of task shifting, it is always ideological debate. It is, oh, the medical versus the non-medical. But if somebody does that sort of research and shows that there is better quality of care, or at least better access to care for people, then the policymaker is going to listen to you. So, keeping all this in mind, I think we have a long way to go if we want to reach universal health coverage. And as a research community, there is a tremendous opportunity to help the policymaker make informed decisions so that we can move on our path to universal health coverage.